Hello learners, are you looking for a master's degree program in mathematics that teaches you more applications? If the answer is yes, then the program MSc in Mathematics with applications in computer science offered by the Indira Gandhi National Open University in open and distance learning mode is appropriate for you. Let us see some salient features of the program. For admission to the program, you must have a major or honors degree in mathematics. You are also eligible if you have studied 3 subjects with equal weightage at undergraduate level with mathematics as one of the subjects. Mathematics and computer science have always enjoyed a symbiotic relationship. Mathematics has helped in providing a solid theoretical basis for computer science, whereas computer science has enriched mathematics by posing interesting problems that can be solved using tools of mathematics. Because of this close relationship, the program team has designed a curriculum that has a judicious mix of core mathematics courses and exciting elective courses on some of the current applications of mathematics in computer science. This program has 64 credits divided equally over 4 semesters. The medium of instruction is English. The core mathematics courses include algebra, real analysis, complex analysis, programming and data structures, differential equations, probability and statistics worth 34 credits. The 26 credits of elective courses are on graph theory, image processing, soft computing, cryptography, coding theory, computer graphics. Some of the core and elective courses have a practical component consisting of computer-based programming exercises that implement algorithms and techniques taught in the course. To give you some hands-on experience, the program has a project at the 4th semester. After completing the program, you may join research institutes, industry or teaching profession at any level based on your interest and aptitude. You can join the program
Namaskar. Welcome in the live interactive teleconference of MBA in Healthcare and Hospital Management. Today we are going to talk about the management information system in health. But before going into the topic, there are few important messages I would like to share with you. We are repeatedly receiving queries like you have not appeared in first semester examinations, whether you can appear in second semester examination in June, or you can appear first and second semester all exam in June and subsequent. The same for the assignment also. So here the clear-cut message is whether you appear it or not, you have total 4 years period if you keep doing the re-registration for all the semester like second semester, third semester and fourth semester. This is a 2-year program and you get 4 years period where you can have opportunity to complete your program including assignment and term examination. So this is a blanket message for all of you, and I think there should not be any confusions on this issue in future. Thank you. So today we are going to discuss about the management information system. As you know, the information system is these days very important, and this is a huge challenge to manage the information system in a hospital or healthcare system. You may visit many hospitals where they may send you one window to another window to collect different kind of reports, or you may visit some kind of health institutions where they are sending you different windows just to get informations and to provide information. So as a healthcare personnel, this is the challenge, how we can manage whatever informations we have more efficiently, and what are the different kind of aspects involved in this process. So to discuss all this issue, today we have expert from All India Institute of Medical Science, Dr. Anand Krishnan. He is a professor in Community Center for Community Medicine, and he is also my teacher. Welcome, sir, in IGNOU studio. And sir will describe you about the different dimensions of management information system in health, and I hope all you will be benefited through these discussions. If you have any queries, you can ask in between through phone. Phone number is displaying on the screen, and you can interact with us. Thank you, sir. It's over to you.
Thank you, Biplab. So as told, I'm planning to cover the issue of management information systems in health. So at the end of this session, I expect all of you to understand the importance of HMIS, what are the basic principles on which HMIS is built. When I say HMIS, it could mean hospital information system, it could mean health management information system, both. I would be using the HMIS term in a more generic sense, especially what the flow of information, and I would also specifically discuss some national health portals or HMIS related to programs, and what are the critical gaps in implementing HMIS in developing countries like India. To start with, if you all must be familiar with the WHO health system framework and building blocks of WHO health system. It says 6, and nowadays we add the 7th one, which is the community. Out of the original 6 building block, 1 is on information systems. So you can understand it is considered as one of the most critical building block of any health system, because that is what will help you see, plan, that is what will help you see whether you are making progress, whether you are achieving your outcomes. All these questions will be answered by a health information system. And by definition, it is a data system which is specifically designed to support planning and monitoring and evaluation, providing alerts to managers and supporting decision making. So largely information is related to decision making, and that's a very critical point that you all should remember. And in this context, it could be either a clinical decision making or it could be a managerial decision making. So this has implications in the sense that if that information does not help you make decisions, then it is an information that you should not be collecting as a part of HMIS. Next, coming to, in general, when we talk of information system, we talk of 3 things: data, information, and knowledge. And many people use them almost synonymously, whereas they should not be using it. Data is a raw material or just a number which you have gathered by collecting either from a register or from other systems. Numbers, remember that any number is actually useless piece. You cannot interpret a number, right? For example, in this I use number of patients screened for diabetes in a sub-center or number of patients in an OPD of a hospital. That number is a number. It is, unless you have something else that you can use that to convert it into information, which looks at in the reference to a context. For example, what is the coverage of screening for diabetes? So instead of, in addition to a numerator, which is the data, we also include a denominator, then that converts that data into a more piece of information, and we get information on coverage. Similarly, it could be workload. If you come a number of OPD patients, you divide it by doctors, get a workload of workload of doctors. So that is how you convert the data into an information. And finally, knowledge. When we compare it with what we want, what is an optimal, which is, for example, if we want 80% coverage and we are only 60%, we know that our coverage is optimal. Or we want doctors to see only 10 patients in an hour and they are seeing 20, then again. So this helps you improve your knowledge of how the system is working. And as I said earlier, this should be resulting in an action, either to improve your vaccination coverage or increase more doctors in the OPD so that you have less workload on the doctors. If you look at any component of an HMIS, it will go through this process, which is first and most is the data collection. Obviously, somebody generates the data, whether it is at the patient consultation or a immunization session or a surgery. So that's where data gets generated. But somebody has to get that data and put it into the system, which is what we call as data collection. Then that data goes in a channel of the system, which we call as data transmission. And every information system defines this data flow, and I'll come to that later. Then it reaches a person who processes this data. As I said, it converts the data into sort of an information. And then sends it further for data analysis and knowledge, and then for decision making by planners and management. So this is what is typically seen in any HMIS. And so I'm not sure you can see these slides, but these are implications. So first, when you are looking at data collection part, then you have to obviously look at how do you collect that data? What are the tools that you are going to use to collect data? Here it is very critical to remember what information to collect. Most often in almost all HMIS across the world, we often see that lot of data is collected which is never used subsequently. Either planner, managers, researchers always want more data, whether or not it is used. So the first question is to look at what information needs to be collected and how it is to be collected. Who is going to collect it? Is it to be digital? Is it to be physical? Is it by a health worker? Is it by a pharmacist? Is it by a doctor or by a nurse? And how will it be stored? Is it to be taken from registers or a OPD register, lab register? So these are the issues that have to be dealt at collection level. Then is the process of collection, as I said, how simple you want it to be, how complex you want it to be. Whether it should be paper-based, whether it should be only digital or both, because then that also determines how much training is undertaken. Then transmission, today almost transmission automatically means a digital transmission. Nobody nowadays does any physical transmission of data. But then you need to keep some timelines for it. Within, for example, we say that annual report should come within 5th day of next month, and it should go to whatever next level by 7th day and stayed by 15th day or something like that. So data transmission is invariably a time-bound activity, which the system should be doing it and should create necessary mechanisms for this transmission. Then analysis and synthesis. If nobody looks at that data, then it is actually completely waste of time and energy and resources. So there has to be a system which helps you do analysis. It could be an application, it could be a human interface where a data entry operator or a program manager or a scientist looks at this and converts this into more information. And finally, somebody converts that into a format for decision making for a program managers. It could be from a dashboard where we'd like a more simpler presentation of data in terms of percentages or bar charts or something like that, because that helps decision makers to quickly arrive at decision. So this would be part of any decision making process, health information system.
Sir, actually in this context, regarding the health information system management, like we have many other information system, like banking system also use some kind of information system. Like all these business establishment, they're also doing their own customer base information system. So how this health information system is basically different from those kind of other information system? Is it the same kind of things, or there is some kind of difference?
Largely any managerial information system will do the same things, which I said. It will collect some data. What data is collected will differ from whether it is a finance related or it is a health related. The only specific on health is health also has a lot of sensitive issues which will lead to
privacy related.
Privacy related, more technical issues. There might be, for example, images. So it might be, so it might differ in the types of content that is used to make the data, but the process remains more or less the same across the different systems, information system. Within the health sector, we largely have three kinds of information system. One is the public health system, and I will talk more about it, not because I know more about it. Then is the clinical information system, and third is the hospital information. Public health is largely focuses on monitoring health of populations, which looks at various national programs and how they are being implemented and how they are being evaluated. Whereas a clinical information system is mainly improving the quality of care. It provides the treating physician and the team with information necessary to provide the correct treatment to the patient. So it is more clinical decision making related. The third is a hospital, which is largely managerial, so that we have necessary HR, resources including drugs, medicines, HR, being provided at the right place at the right time, depending upon the patient flow. They all can be part of one big information system, and each can give some input into the next one, or they could be three independent also. So again, just taking the same thing again, as you can see in the left of my left, you can see the national level, largely public health information system, where data usually flows from populations, which is subcenter or SC, and then it goes to primary health center, then it goes to community health centers, then to district. So there is always a chain of command, and information flows from lower place to higher place, with obviously national level being for centrally funded schemes. Nationally will be the highest level. For a state funded scheme, state would be the highest level. And at each level, somebody is supposed to look at that data, not only to ensure quality, but also see what decision making. Remember, most decision making occur at lower levels, not at higher levels. So while the information flows up, most of the decisions occur at lower end, and that is one of the problems with the most HMIS. The other, on the right side of mine, you look at the typical hospital-based patient management system, which looks at patient registration, clinical and resource appointments, billing, payment, and all those kind of a things. So it's a mix of both clinical service provisions and appointment, as well as for billing and those things, and including laboratory management information systems. Again, Dr. Biplab mentioned it in his initial introduction. One of the things that information systems can do, it is not that information systems are only useful for managers, they can also be incredibly useful for patients. Like initially, like all blood collection or sample collection can be centralized, similarly all information can also be centralized, and everything can be done and provided to a patient at one point of contact. It is not necessary that patients have to run, or the relatives have to run for laboratory to one place and for medicine to some other place. So again, it depends on us. The scope of information system to simplify both managers and patient experience is enormous. It is up to us to exploit it fully. So many of you would also be useful, be planning to design some HMIS, but also these principles are useful when we evaluate HMIS. So first is, as I said, there are different levels in HMIS, and different people have different roles and therefore have different data needs, and would therefore need different types of data and data access. HMIS is not a single entity. HMIS is a multiple entity actually. Everybody would see it from a very different angle. What subcenter person sees in that HMIS will be very different from what a national person sees in that HMIS. So even though they are part of one system, their experience of that system could be very different. Second, the point that I made, not all that data which is collected which needs to go to higher levels. Because decision making occurs at lower levels, all information should be available to a lower level, and aggregated information goes to the higher level. For example, individual level data should be available to subcenters so that workers can take individual level actions. However, at the PHC level, you don't need individual level action. You would need to see how each subcenter is performance. Similarly, at district, they would like to know how each PHC is performing, and so on and so forth. At state level, they would like a district level aggregate and those kind of things. And it is not that an HMIS has to collect all data that is required for decision making. HMIS is one channel through which data is collected. There could be other channels. In India, one best example could be the National Family Health Survey or SRS. Many of those things provide a lot of critical pieces of information for health management and planning. And therefore, we don't have to necessarily put every data through the HMIS, because they may not be amenable to collected through HMIS, especially population-based data are not that easily amenable to collect through HMIS. It will require enormous amount of work. A survey might be a better way to do it, because it does not need to be done on a daily, day-to-day or monthly basis. It could be done every few years. Then a lot of thought has to be given on how we collect data. What are the data designing tools? What questions do you ask? And invariably, as I said earlier, we tend to make our data collection tools unwieldy, put a lot of questions there without a thought on how it will be used. We just say, no, it will be used. I am sure both important data we should collect. Somebody will find use to it. But that is not how a data HMIS should be designed. because it increases the workload of the staff who is filling it, and also has implications for data quality. If you want a health worker to collect a lot of data, obviously at some point of time he is going to want to do things faster and would compromise the quality. So these are very critical things which often get neglected when we design HMIS. So as is true for everything, you should keep data collection and its tools very short and simple, and not add more and more variables into it. Processing should be inconsistent with your data analysis. So again, we have to be very clear what are the indicators that are going to be generated by this. For example, if you are looking at a national program for immunization, we should be clear what are the key indicators for to be generated through the HMIS, and collect data to answer those indicators, and don't collect data which are not required. For example, obviously for an indicator we need a numerator and denominator. In fact, that is all. And plus some stratification, for example, by gender or by socioeconomic status. Those are the critical pieces of information that you should collect through the HMIS. And HMIS, we feel it is very simple to use HMIS, but often HMIS require very complex training programs for users, especially as we move more and more into digital collection and also create a lot of applications. We need much more training for people to use these things, and they should be pre-tested. And most important thing again we forget is that often, as I said, the data flows from below to the upwards, but nothing happens from upwards to downwards. So person who collects data actually does not know what his or her data has resulted in. They are never told what has happened to this data. They are never told about the quality of use. Again, if you go to any HMIS, everybody will say, oh, HMIS is as good as the quality of data that it has. But the question remains, what have we done to improve the quality of data in that HMIS? If you are asking too much information, if you are not training them well, if you do not have validity checks, then quality of data will remain suspect, and the whole purpose of HMIS would be lost. And this is something which happens very often in public health systems, which we should be careful. And no HMIS is permanently ready. Because programs evolve, people evolve, needs evolve, HMIS continuously evolves. It is not a one-time activity, and as long as it is done in a very thoughtful manner, it is a good thing for HMIS to keep evolving and not remain stagnant. Today, we know that for any HMIS, it is a digital backbone. Today, we cannot talk of HMIS without digital backbone for it, because everything is today digital, from data collection to transmission to analysis to processing, everything. And we use either softwares, portals, applications. These are always used, and resulting in increased need for hardware, softwares, internet connections. Again, we often are more keen on providing these softwares, but we do not give enough attention on for example, if there is no electricity available, if there is no internet available, all this may not really work. So while digital backbone of HMIS is very important, simultaneously we have to also work on improving the digital infrastructure in many of these health facilities, or at least provide offline, that at the time of front end there should be possibilities for offline working, which can get synchronized at a later stage whenever internet is available. And so there are a lot of issues related to this, including in HMIS, unique ID, data collection tools, where will the data be stored, how safe would be, data analysis and decision support, reporting, and those kind of a thing. And I will touch upon many of these things subsequently also. Most important requirement for any, whether it is hospital or population-based HMIS, is a unique health ID. And I'm sure there is a lot of action occurring in India, especially related to Aadhaar ID, but and there are a lot of concerns also with it. But I can assure you, while the concerns may be valid, the need for a unique health ID which links different data sets is critical. You cannot have a comprehensive HMIS unless you have every individual listed it with a unique ID. That will only help you to be interoperable, to move from health facility to health facility, from public to private, from upper level to lower levels. If you want that kind of seamless interaction with the health system, the only thing that can enable you to do that is a unique health ID.
So, sir, if I understand you correctly, like, for example, we have public health information system as a TB patient.
Right.
He has a one health ID, but the same person is having registered for the COVID vaccines. He has a different unique ID.
Right.
So, and he may be visiting for a hospital for a different element. So he has another unique ID. So none of these unique IDs are matching, and there cannot be integrations.
Absolutely. So if there is one unique health ID, it could be because Aadhaar has its own implications. Therefore, we are creating a separate health unique ID so that we don't create other kinds of problems. For example, as you rightly said, if somebody is being treated for tuberculosis under our TB program,
Nikshay.
Yeah. So he would be in Nikshay portal. Similarly, he also might be diabetic, and he might be under our NCD portal.
Yeah.
But our left hand will not know right hand, and right hand will not know left hand. But it is important for both the programs to know, because diabetes has impact on TB outcomes and TB has an impact on diabetes control. This information has to be shared. So unless we create a linkage variable, which is I'm calling as unique health ID, you cannot do this. And he might have multiple, as we age, we are going to have multiple comorbidities. Therefore, the only way to do it, and also today I might be going to I might get transferred to another hospital city.
Yeah.
So what do? If I have unique health ID, irrespective of where I am in India, I can access all my documents, my records are interoperable. So a unique health ID is a must for a really operating, whether even in a hospital, you would like to have, every hospital has unique ID, which links its laboratory, its pathology, its OPD systems.
But again, sir, challenges is this government, private is again not merging with each other. So there is a data transmission related issues.
So those issues are there, they need to be addressed. But without unique ID, we don't even begin addressing them. Right? So that's the first step. And obviously there are safeguards have to be built in, but that is obviously necessity for those kind of things. So one of the things that we should be promoting, any health manager should be promoting, is more and more people adopt unique health ID. So I'm going to give an example where I have worked earlier, and we perhaps created one of the first health management information, computerized health management system in India at Balabghat, which is a field practice area of AIIMS, where we actually gave unique ID to 13-digit unique ID to everybody who was listed under us. This happened in 1990. We can see it is all 45 years back. And though everybody got listed as a population database, and everybody got an unique ID. Unique ID could be partly logic and partly random. And we created then modules for immunization, we created for tuberculosis, for maternal health. Again, why did we do this? Because it was important to ensure we were looking at very high coverage for vaccinations and maternal health coverages, which was low at that point of time. So if you are able to list all your eligibles, and then you can easily actually go and ensure that they get vaccinated. Most often in Indian public system, we don't know who are our eligibles. So if you don't know, you don't have a list of eligibles, there is no way you can have a high coverage. So the first step for any program is to know whom should I be catering to. So then based on this thing, obviously as digital system evolved, we moved from a MS-DOS system to FoxPros. And today we are in a MySQL. So it keeps changing depending upon your ability to handle and as technology progresses. So I'm just giving you this. So you can see this is what we call as work plan. So it identifies everybody in that household. So if a worker visits that households, it tells you, okay, there is this woman with who requires this child who requires immunization. Please provide immunization. Or this woman who is antenatal, who is pregnant. Or this is a eligible couple. Please discuss family planning and maybe give condoms or whatever contraceptive method they are using. So this enabled us to have this kind of delivery of healthcare, household-based delivery of healthcare in 1990s, because we developed an HMS. The same, we have still in India not reached this level of, which is something that we should be worried about. And this is something that we should aim at, that ultimately every health worker should have, in every household, he should know this household has a TB patient, has a diabetes patient, has a child to immunize. so that we can easily deliver our care in a way and improve our coverage with all programs. We could ensure 95% coverage of vaccination in our children in 90s.
I think, sir, you also need to mention some part regarding this unique ID, because every unique ID has its own uniqueness of the village code, their family numbers, the head of the family.
Exactly. So as I said, unique ID is usually long because it has multiple this thing, and there are regulations at least 13 digit long. They should be there. So as I said, it has a part which is logic, which is like, as you said, each district can get a number. It will be village number, household number, family number, and all members. So for example, all members in the family, head of the household will end with 1, wife will end with 2, first son will end with 3, and so on. So that we can also link individuals. Otherwise, your data might list husband and wife as 2 separate individuals, and you will have no way of linking them. So if you have a logic till household level or family level, you can use it to link mother to a child, father to the wife, spouse, and those kind of a thing. Yeah. But at the same time, a part could be completely unique, which is randomly generated, so that it maintains unique identity, so that it is not easily, otherwise, if it is purely logic, one can actually guess the unique ID. So keep the uniqueness, you can have a second part which is more randomly generated. So similar experiences have occurred worldwide, and this is the District Health Information System, which was started by WHO, which is built around the same thing that I said earlier, but it's an open source web-based platform, and many countries have adapted this for their own countries. Again, it has, you can build applications on it, and so DHIS is a good model where, and as you can see in the diagram, those kind of display features can be added to this HMIS and helps decision makers look at the key variables, indicators. So I will just briefly describe the current HMIS in the National Health System, which is the National Health Mission, the NHM. Again, we have an excellent HMIS through NHM, which Government of India has launched in October 2008. It covers all the national programs, as you can see, RM and CH, immunization, family planning, vector-borne disease, and also we are now given an health, every health facility has got an ID. So a lot of those things are important. So unique ID of patient is important, unique ID of health facility also helps you manage these kind of a thing. And again, if all infrastructure, equipment, manpower, all linked and mapped, then it makes it management very much easier. The key problem in our HMIS, and as we discussed, is that we currently have we have many initiatives, as you can see, Nikshay, CoWIN for immunization, there is an Anmol for RCH or mother and child tracking system. So these all are excellent, but they all are vertical. They are not all integrated. So as you all will probably know that there is a lot of enumeration of households being occurring as a part of our NCD program. But the plan is that once everybody gets enumerated, it's something the same way that I said we did in Balabgarh, then it will be possible to give them unique IDs, and then possible to link these programs into one. We are struggling there, but that is clearly an idea that is there in everybody's mind, in the government's mind, and it will happen hopefully sooner than later. So as you can see, there is an RCH portal which looks at family planning, maternal health, child health, immunization. It collects a lot of quantitative factors, but obviously a lot of community-related issues are not covered by HMIS. HMIS almost exclusively covers health system issues, right? So sometimes we also have a parallel NHM reporting, which is either a paper or digital, and many of that, this time we have to do duplication. Some information goes both in the RCH portal as well as in NHM portal. So because we have multiple vertical portals, we still have to do a lot of duplicate entries in paper, in digitally, for one for this program and for some other program and those kind of a thing. So while we have made excellent progress in creating vertical portals, the challenge is still how to integrate them. And for example, Nikshay portal enables even private sector to provide inputs into TB patients that they are. In fact, it mandates them. Today, TB is you have to report mandatorily. And the way that they can do is that they have to enroll themselves in the Nikshay portal and then add patient details, so that then previously we used only the data on people on tuberculosis who are being treated under the government system. But today, this portal enables us to know the patients, tuberculosis patients being treated under private care system also. So again, that's the way that we bridge. So only CoWIN, initially created for COVID, but today expanded to include for all immunization program, was excellently used extensively to manage our immunization delivery for COVID-19 vaccination program. We also have an NCD's portal, which is the most recent, again, which looks not only at how people are screened, what happens to them after screening, do they go to a facility for confirmation, do they get diagnosed with hypertension, if yes, they are taking treatment, and the system generates the chart that you see on the top is a system generated one. It tells you where is your, how well is your national program working, how good is the screening program, are people who are screened positive come to a health facility, do they get diagnosed. So a fallout of this cascade through this diagram is a very important decision making tool for managers. They know where to focus. So again, as I said, a good HMIS has to be linked to a decision making. There are challenges in this because the enumeration is done by ASHAs, it gets entered into digital, getting data input into the system, because in health system this occurs at multiple levels, at ASHAs, at ANMs, at sub-centers, at primary health centers. Integrating them is still a challenge, again because of lack of unique ID. So for example, a patient might get screened by ASHA, might also visit a health center, but you may not be able to integrate the two. So while we report numbers who are screened, numbers who are diagnosed, we still don't have a way to look at it from a patient perspective and see how a patient, because they are not linked by unique IDs. If when a patient presents at a PHC, he has no unique ID to present. Till we solve this problem, this is going to be there. But this is, as I said, very important, especially as we move towards chronic diseases and we move towards, because then only if somebody from PHC is referred to a district hospital, the data will automatically go on the computers and can be done. So for a good information system, that is very important. Hospitals also have e-hospitals which look at different aspects, including, as I said, patient registration, OPD, lab, store, pharmacy, billing, everything. So today in many private and many public hospitals, you don't have to go to collect, doctors don't have to go to collect lab reports, or the lab reports do not come on paper. They all are easily transmitted digitally. You could be sitting in your ward and click and see what are the lab reports of different people. So obviously, and similarly, nursing staff could look at what is the store, laundry, all these things could happen through HMIS and hospital-based information systems. One of the concerns for all of us should be the security of HMIS. As we move digitally, security becomes very important. As you all know and must have heard, AIIMS was one of the victims of a big breach of data and piracy. So, but that is becoming very important. Obviously, we need to look at there would be hackers, as in case also, or there could be security breaches, power backdowns. There could be people with who are in the system who might steal the data or sell the data. We might have somebody else, you might be using a third vendor's party software as a part of your HMIS, for example, for laundry or for stores, and there could be breach through that, through internet, this thing, and obviously it could be through flood, fire and cylinder, which can impact any hospital, and we need to protect our systems from all of these hazards. Through access control, through securing the internet use and data storage. There are enough regulatory, including HIPAA mandated requirements, administrative, where you define the roles and responsibilities, who will get access to what, who is authorized for physical access, how do you dispose your hardware, and those kind of things have to be thought through and have to be ensured before we move entirely digitally. These are very critical pieces of information, and we need to be up to date in doing this kind of a thing. So Many of you might not design the framework, HMIS, but you might be interested in evaluating some of the HMIS that are existing either in your hospital or in your health facilities. And I'm just giving a suggestion for a framework which is called as a PRISM framework for evaluating HMIS, which looks at the inputs, processes, outputs, outcomes, impact, which is a logic framework that used for any evaluation. And they are listed there, including technical factors, organizational factors, behavioral factors. So this is one of the things that you have need to know. Very often we think that HMIS does a digital solution. It's a technical tool. But remember, effective use of HMIS has a lot of organizational behavioral aspects as well. And you cannot effectively use an HMIS unless you address those issues. Because, for example, HMIS can improve accountability in a system, but people may not want accountability. People may feel that if and this is a real challenge which occurs. People may say previously they could write, they could even make fake entries, they could give some numbers, but HMIS prevents those kind of things from occurring. So HMIS improves accountability, but therefore the health workers might resent use of, or people who are using it might resent. And sometimes it also issue of, because we think information is power, we don't like to share information. HMIS increases transparency, and therefore some people lose power which they have over the information. So these are issues, very important issues in effective use of information systems, and have to be dealt apart from digital and technical solutions. So I'm just giving some examples here. Very often again we make it as HMIS, but the people who have to use it do not have the competency to use the data which is there in the HMIS. And these are the evaluations which have shown that many of the healthcare managers at the district level don't have basic understandings of how to calculate an indicator, how to generate a graph, how to interpret or either make a bar chart or how to interpret a bar chart. And these are very low HMIS task competencies. These are not very high-end HMIS task competencies. These are basic task competencies which were expected from health managers. But studies from India as well as abroad have shown that many of these health managers lack some basic HMIS related competencies because they were never trained, and they were assumed that these are very simple competencies you don't need. So I will end with key challenges, and again this will repeat many of these things. First, structural. Lot of multiple institutions, vertical programs, they all work in silos and develop their own data collection system without any coordination or interoperability. This simply cannot work. You cannot have separate HMIS for different parts of a hospital or only for separate districts which will not work at PHCs, or only for PHCs which will not work at districts. A good HMIS has to work at all levels with all providers. Again, procedural, I said...
Sir, is there any state in India or any particular organization which is having, like even AIMS also, we have more than 20 AIMS right now operating. Are they sharing same kind of things, information systems? Are they integrated? Or, for example, a patient who has entered into the Delhi and tomorrow if he got, due to some reason, he moved to the Jodhpur, then is it integrations there?
Unfortunately, no. You make a good point. So each of them have their own HMIS which is independently developed. It is not that even that is shared. Yeah. And there is no interoperability between these. But you would remember recently, this is a good example that of emergency system. AIMS Delhi initiated this thing by which at least all emergency systems of the major hospitals should pool for bed availability, so that there is a centralized data available and patients can be transmitted. Otherwise, you will go to, for example, AIMS and say, oh, no bed available, they are referred to hospital B. There also they will say no bed availability. So if you have a good, where every hospital contributes that this is the data availability, bed availability, then
without losing time, patient can...
and if this is available through a phone number or an app, then patients can directly go to a place which is nearest to them and has bed available. And if you add that an advanced information system, that they can also put in that this I'm a chest pain patient, I am coming to your OPD or emergency. So if hospitals have advanced information, then it makes everybody's life useful. Hospitals we can do better, patients will benefit from it. So these are the great advantages of having a synchronized, integrated information system.
Like we have, sir, in every state we have many medical college-based hospital. We have a district hospital, but none of the state has ever in the process of doing the unified information system.
I think some southern states like Tamil Nadu are doing much better in this because they went into this many years back, but there are other states are not doing. But definitely today every state in India is moving in this direction and trying to solve these problems. So that is a good thing. Then procedural challenges, again, as I said, we collect too much data. Any HMIS, if you really look at it, and that could be one of the exercises that you could do, that how much of that data is actually analyzed in any of the reports or any of the decision making that has ever happened on that. Different registers, and as I said, no feedback to the person who uses the data, who generates the data. So they feel that our data has not really been used. We discussed a lot of technical challenges, especially related to IT. And today with GPS and GIS, which can be added to this, it will add more complexity, but at the same time make many things easier, especially let's say in an emergency situation. Even the app can say you are located here and this is the closest hospital and this is the bed available. So a lot of these things can happen if you have good information systems. Competencies for human resources, and as I said, work culture. If it really does not matter whether a worker gives 20 vaccinations or 40 vaccinations, then you cannot use this data for decision making. So HMIS also, as I said, enables you to identify which subcenter is doing well. It's a good performance review mechanisms. You can easily write software applications which can generate data for performance review of workers, of subcenters, PHCs. And resource allocation. Ideally speaking, again, if a district has more patients, there should be more resource transferred there. Similarly, within a district, some PHCs would be having more. But unfortunately, in our this thing, it is everybody gets equal amount of this thing, and then they keep running. Some districts don't spend enough, and they get reprimanded for not spending enough. And some districts keep asking for more money, and they don't get. Yeah. Whereas this could be solved right from the beginning if you have a good information system. So I would like to end that.
No, sir. Before ending, one thing I want to understand. Like as you said, digital infrastructure is the backbone of any information system. So now the question is, like developing country like India, how much costly is it? Like and how difficult that maintaining the database, and what is the role of the local database or hiring some kind of server, and is it really per patient very costly or individual wise very costly, or what are the prohibiting factor?
Today I think as most of these digital things are becoming cheaper, apart from the initial design, which might need some high level competent IT professionals, the actual softwares, hardware, servers, I don't think are that costly. I don't think, given the critical importance of HMIS, we should ever consider cost as a barrier for not developing a good HMIS. And I don't think cost is a barrier for a good HMIS. I think in India can easily afford, with our own IT infrastructure and HR, I don't think affordability is a critical factor in having a good HMIS.
Okay. Can we look into in other ways, or as you said, the organizational behaviors also matter a lot, because most of the policy making people sitting at the top, they were never been sensitized on this process. Yeah. And the young generation may be looking into this, but the decision making person never feel it necessary. So is it related to the organizational behavior, or the way we are getting trained throughout the pen and paper, and still we are working on that?
Yeah, so as I said, HMIS is related to decision making. If your decision making is occurring not based on information which your system provides, then obviously HMIS is a waste of investment. And traditionally in India, our decision making was not linked to information. As I said, everybody would get the same, and whatever the policymakers thought right would go ahead. But today we are changing. There are more demands for data and from professionals, from policymakers, from bureaucrats. Today we are moving into an era where HMIS is much more appreciated and used by policymakers to make decisions. So that's a we are moving in the right direction. We may not yet be there, but we are moving in the right direction.
I still remember when I joined in the AIMS, my health worker was so efficient. She used to tell, Dr. Saab, this is 340 household and this mother needs this medicine and this contraceptions, this eligible couple. They just remember by their household name and by the person. Yeah. So that kind of efficiency need to develop across the country to provide.
So those could be an exceptional worker. But we have to accept that most of our workforce will be average workers, right? For average workers to do that, you need an HMS, a good HMS. Otherwise, exceptional workers will always be there and they will do a good job without an HMS also, right?
Yeah.
So just to conclude, HMS is most critical for any health system, whether it is a hospital or a district or a country. But they are complex systems, multiple sources of data, multiple levels, and we need to have a good plan of how to integrate them. HMS have to move from it is not just a piece of collecting data, it has to move from collection data to information to knowledge and decision making. There are critical designs issues in any HMS, but it has to be customized to local context. And as I said, collecting too much data is not a good idea at all. We have very good national program portals linked to HMS, but we need to move towards a more integrated portals for that. And with increasing digital solutions, security and privacy issues will become very important, and we need to invest more in that area. But finally, as I said, HMS is not a digital solution. It requires a lot of organizational and procedural challenges which need to be addressed if we really want to take full advantage of a effectively functioning HMS.
Thank you very much, sir, for giving us so valuable information. I hope all of you are now understand this topic, and related to this information management system, subsequently also will do many other this kind of live interactive teleconference. But here, one thing I would like to request all the students that please keep visiting IGNOU website, because in the IGNOU website we display many informations which is very, very relevant to you. Because now you are the student of management, and if you yourself is not able to manage within the availability of the resources, of course we do agree that we have challenges, because this is you are the first batch of our program. We are also struggling different dimensions, and in this meantime we would like to request all the students, just sending SMS or just sending me WhatsApp may not be bringing the solutions. The solution may be already given in the IGNOU website. So, I hope all students will efficiently manage yourself and making this program more smoothly. Thank you. Thank you very much for listening us. Thank you, sir.
Thank you
very much.